is over to the far left. So you don't even see where I'm seeing patients, but that's our large institution, and we are a level 1 trauma center academic institution in the middle of Winston-Salem, North Carolina. That's me. These are my disclosures. I really do not have any conflicts of interest. Mainly, I talk about fracture liaison service line and not product focus. So, but I do work with the NBHA and National Bone Health Alliance, as well as, industry and really pushing the fracture liaison service line to capture these patients that have fallen in the fragility treatment gap. So just as a general rule, at Wake Forest, we don't use the word osteoporosis when we talk about capturing that patient over the age of 49 that's had a fracture. We do that for various reasons. Number one, we don't know that we're ever going to get any male patients to come to see us because they don't think they have osteoporosis. But we know that 1 in 2 females over the age of 50 and 1 in 4 males over the age of 50 are likely to have an osteoporotic fracture in their lifetime. So we really kind of focus in on the bone quality issue in these post-fracture patients that present to the orthopedic service line. So again, these statistics show, 54 million Americans have poor bone quality, and we also know that 10.2 million have osteoporosis and 43 million have the low bone mass. So, you do the math. If you have low bone mass, you probably have a bone quality issue. If you have osteoporosis, there's definitely a quality issue and a thickness problem with the bone. So we tend to focus in on the total bone strength of the patient. And when we approach a patient here at Wake, after they've had a fragility fracture, we ask them, do you want to have another fracture? And they usually say no 100% of the time. That's one thing we can guarantee 100%. And we just basically tell them, we're here to help you meet that goal, and that's to help you not have another fracture in the future. We have basically a broad definition for our patients. We explain bone strength is equal to 2 things. It's equal to your bone density and your bone quality. Your bone density only tells us how thick your bone is, but if you have a piece of particle board that's this thick and a piece of oak this thick, which one would you want to build your house with? And then they begin to understand what quality is all about. So we explain that to them, and we also talk about the remodeling process and those kind of things. So again, what is the issue with these fragility fractures and of course osteoporotic fractures? Well, we get paid on how often our patients come back to the hospital, what their quality is. If they die under our care, we may not get paid in the future. I mean, there's a lot of issues involved, and I can use big words like morbidity and mortality. When we pull it right down to grassroots, it's really all about improving the outcome of the patient and the quality of care that they receive. And we know that the fracture service line can help us do those things. We know that hip and vertebral fractures particularly are associated with decreased life expectancy. And we also know that, around 24 to 35% of hip fracture patients 50 and older will die within that first year following a hip fracture. This is an NOF statistic. So estimated cost, everyone's aware, we're really looking at that looming cost of $25 billion going forward. And that's really because we have a population surplus of patients actually turning 65. So I call it the silver tsunami. That's not my term. Love that term, but that's what it is. And I happen to be in that group. Well, not yet, but almost. So here we really focus in on that secondary fracture patient, that secondary fracture risk patient. And we know the risk fracture patient, the patient that's had a fracture, their risk of another fracture increases exponentially. Hospital cost related to osteoporotic fractures. Again, osteoporosis is not a pretty disease. This is a beautiful slide. I borrowed it from Dr. Andrea Singer. I want to give her credit for that. This was a study from the Mayo Clinic. It basically shows that there's more hospitalizations related to osteoporotic fractures than treatments for breast cancer, stroke, and heart disease over the course of a 12-year study. And what's interesting is even though the slide's beautiful, osteoporosis is not a pretty disease, so we don't have the pretty ribbons and all of that. So there hasn't really been a focus on really looking at what is the total cost of care related to this patient population. So we believe that the FLS service line really helps improve the patient population health for those patients in our community that are served, not only by the orthopedic providers, but also engaging the care and the specialty of the primary care providers and other specialists that happen to be involved in the continuity of care for that patient. So the FLS model is this care coordinated preventative care model. Preventative, not necessarily from prevention of osteoporosis, but prevention of future fracture. However, across the country, and I know that Dr. Schwartz and Dr. Olenjinsky can actually, attest to this, that there are many hybrid fracture liaison services across the country that include not only secondary fracture prevention, but actually primary prevention as well. So this care coordinated model actually identifies the patient at the point of entry, at the time of fracture, and then the FLS coordinator is usually identified as the advanced practice provider, who actually will help identify the patient and begin the investigation, initiate treatment, and help with coordination of care. You'll see in just a moment that part of that team, a critical part of the team, is the nurse navigator that plays a huge role in helping with data collection, patient education, and many, many other roles. There's also data registries out there, and I know there's several different ones that we can certainly talk about on a different day. But right now we do not have a formal registry program. We've actually been using an Excel spreadsheet to track our data, but we are looking at beginning to use another program in the near future. We also know that these particular programs will actually identify patients who are at highest risk for another fracture, and of course, increasing healthcare dollars and also decreased quality of life. So I want to say hello to all the people that are joining us. I appreciate it. It looks like we've had 9 more join. I cannot see all your faces on my screen, but I know you're there. So I appreciate you coming on. So again, this is a care coordinated model. The most important thing about the fracture liaison service model that we know here at Wake, and also through the research that has been done on this particular service line, the 3 things that need to be in place if you're going to have not only just a successful program, but also a sustainable program, is that you be able to identify the point of entry, and that you have some mechanism for having an investigative process going with the patient. Most of the time, that's usually on an outpatient setting. We found that works best for us here, but there are other specialists that do have an inpatient process as well. We just felt that it's more cost effective for us here at Wake to do it more on the outpatient side. And plus, actually, logistically, as a nurse, I found that patients are not as engaged in the hospital to talk about more treatment. They just want to know how, after the fracture, that they're going to get to the bathroom and be able to get home. So those are the main things they're focused in on. So we basically introduce the program to the patient, and we do the investigation and the initiation on the outpatient side. So another beautiful slide, which I love, you actually can see how this is really a care coordinated model. And the patient, even though the patient is part of this circle that you see, really the patient is really in the center of all of this care. So it's very important that your fracture liaison coordinator and your clinician that's doing the work upon your patient really be able to take a whole patient look at that patient. In other words, not just looking at the bone problem. So if it's an orthopedic provider that says, yeah, they've got, crappy bones, that's one thing, but they may have crappy bones not because of just age, but it could be because they've been on seizure medicines for years, or they could have been on PPI medications for years, or they could be on non-steroid COPD medications or steroidal medications for years that have affected their bone quality. What about chronic opioids? So there's multiple things, multiple layers of things that can certainly be affecting what's going on with that patient. So your clinician needs to be a provider that can actually look at the whole person and see what multi-factors that could be involved in here. So the orthopedic surgeon plays a role, other specialists if the patient's under the care of rheumatology or endocrinology for various reasons, the primary care provider if they've been on treatment in the past and maybe failed treatment or their bone densities didn't improve, etc. Physical therapist, and certainly family members know if the patients have fall risk and those kind of things. So keeping that in mind, it is a multidisciplinary approach with the patient in the middle. So again, the 3 I's would be identifying the patient. Here at Wake, we like to say greater than 49 because we feel like everybody's always looking for an excuse to not include somebody on something. So if we say greater than 49, we're going to get the 50-year-old instead of missing the 50-year-old. So we say greater than 49, and then investigation, of course, the medical necessity of the evaluation for secondary fracture prevention and to give the treatment recommendations, and then, of course, initiation of treatment. So there is another research article out there as well that Dr. Schwartz and I know my other colleagues are aware of, about the 5 I's, and it's about investigation, initiation, and treatment of therapy, but it also talks about importance of follow-up with the patient and making sure they're staying on treatment. Well, that's just part of our protocol, because if I'm going to start a patient on a new treatment or a medication, I'm going to have them follow me because my name's on that script, and I want to make sure that they're going to continue with their treatment, and that if there's any reason that they had to stop therapy, that I'm the provider that's taking responsibility to help make sure that we maintain their treatment. So there are many other in FLS care out there. This particular model that we do here at Wake is primarily driven through the Department of Orthopedics, because when a patient presents with a fracture, they come under our care. So we have found that model works best here at Wake. Some of the research had shown that there's a little bit less attrition in the post-fracture phase of care. Patients will usually will be when they're under the care of the orthopedist, and they're already getting their physical therapy and their pain management and those kind of things. They're already sort of in the mindset of, how do I keep this from happening again? So it's a very good teachable moment. And so we like to capture them in that immediate post-fracture period. It also helps improve care coordination and communication about the patient with the primary care providers and other specialists involved that will help improve the goal of reduction of secondary fractures. There are multiple other models out there. I would say probably what I would call hybrid models, where the patient is actually captured by the orthopedic provider, but then they actually are then referred back to primary care after a treatment recommendation is made, or they may be referred to another specialist. The only challenge that I have with some of those models is that initially, when we started talking about fracture liaison service line in the United States, that was something that was already being done. Orthopedic providers were saying, well, let's just send to primary care. And then primary care has been inundated with so many other disease management things that they have to manage. By the time they get to the O's, it gets very challenging to address that with patients. And so there seemed to be a little teaching deficiency there, and patients were just they were either started on treatment and didn't continue, or maybe they were started on treatment and then no one really ever followed it. So there's multiple research out there. We're doing a little bit better in primary care, and we really hope that more of our primary care specialists are going to, see that we're trying to support them and lift their arms up in what is a very daunting task with all this chronic disease management. So with that, and somebody, if you can turn your speaker off, we have a little bit of reverberation going on, so you can mute your speakers, that'd be great. The other models that often are in place are referring to specialists, and that would be wonderful in an ideal world. We do have some insurance issues related to referrals. We have some payment model issues related to referrals, especially with ACO models and those kind of things. But the other big challenge is being able to get the patient in for access to care, because these specialists, they are dealing with multi-specialty issues, and they're dealing with these really disease states that really are very challenging. And so sometimes to get just a regular osteoporosis patient in with the specialist, I know here at Wake Forest right now, the wait to get in to see an endocrinologist is around 4 months. So that makes it really, really difficult. So we like to try to get the patient in and get them started, and then do the appropriate care coordination after. But again, many, many models exist. And again, it's very successful and adaptable to any healthcare system. You just kind of have to look at what you have in place and what would work best for you. These are your team members. Not that I'm going to skip over the physician champion, but basically the physician champion is just to sort of stay at the helm and help with power issues and justification issues for the full-time employee, and sort of help rally around, the just cause of why the FLS service needs to be in place, and with institutional buy-in. But actually your main leaders of the team are going to be your FLS coordinator, which in the more common successful models have been advanced practice providers with either a collaborative physician, whether it's a specialist or an orthopedic or primary care, but a collaborative physician that works sort of alongside this nurse practitioner PA. But in general, this particular role is more of an autonomous role that does not require direct physician supervision, and the APP is very, very well capable of being able to manage these patients based on whatever their laws are in their state. And so this also allows quicker access to care. Usually advanced practice providers have a little bit more flexibility and openness in their schedule, and also a lot of times we are more in a place where we have time to do a lot more education for the patient. We do work closely with the physician champion in order to build the program, as well as other physician providers within the organization, and to make sure that we are, all on the same page with that. The other thing is this particular program does help with organizations to maintain meeting some of their quality measures and their guidelines. And so it's important to know that if you have this program in place already and you're kind of trying to strategically plan ahead, look at what your organization has in terms of their quality care program or the reporting model, and actually see if you can get them to recognize what you're doing in your service and begin to report on those, because it's only going to help improve their outcomes as well, and actually help incentivize with reimbursement going forward. The nurse navigator's role, of course, is to support the fracture liaison coordinator and clinician. Specific roles related to osteoporosis education, medication administration. Maybe we actually have a nurse injection clinic, and so my nurse is able to give the maintenance injections as well and do some injection training. A lot of the prior authorization. And one thing I just want to point out to you, if you're doing this, you're going to need some support staff as an FLS provider, whether it's you're a physician or a nurse practitioner or a PA doing it. You need some supportive staff to help you, because there's no way that you're going to be able to do all the prior authorization and the paperwork. And I'm going to turn my camera just a little bit to my nurse. There she is right there, Mayanda. And she's the one that really keeps the wheels rolling for us and for our patients, making sure things happen. But just keep in mind, it's not going to get easier from here in terms of authorization for medications, because here's the status. The bottom line is everything going forward outside of an oral medication is going to require a prior authorization of some kind. And so we're going to be doing this PA process and verification, because these are specialty drugs. So if you can develop a system early on, it'll be much easier for you going forward. I'm going to skip over some of these slides here. This just talks about the electronic records and the ancillary services and some FLS promotional programming that you can do internally and externally. I wanted to leave those in here for you so that if you want access after the program, you'll be able to get it through the iEcho library, which Andrea can address for you later. But I just wanted you to be able to have these as you're looking at your program and maybe even continuing to develop your program. So really, regardless of whether you're just FLS 101 and getting started and you just put the shovel in the ground for groundbreaking, or you're into it 4.5 years like we are here at Wake, all of this information is very helpful, because it's just part of the strategic plan that you want to have in place, not only for that successful program, for that sustainable program. So if you can see on this particular slide, it talks about networking within the health system, other providers that would be could be part of the team and part of the, what we call feeders. So your FLS would be the treaters, and then you have feeders to your FLS model. You're always going to need some specialist involved with your patients, especially your kidney patients and maybe your patients that have some endocrinology issues or rheumatology issues, your chronic pain medication patients. So a lot of options here with networking. We recommend starting, obviously, with the low-hanging fruit with a secondary fracture prevention program, capturing that patient immediately in the post-fracture period, and then progressing stepwise. Once you have those pieces in place, you progress stepwise to start capturing the patient greater than the age of 49 of all low energy fractures in patients. Now, I'm going to make a bold statement here, and I can quote Mike Lewicki on it. So everybody that knows Mike Lewicki, you'll know. But if you don't know Mike Lewicki, you should check his Project Echo bone program out as well. But he is an excellent provider, an excellent mentor for the FLS service line, as well as osteoporosis treatment and management. And basically, all these boneheads around the table are now saying aging is a chronic disease. So therefore, we need to look at osteoporosis as a chronic disease, and we need to look at any fracture that occurs in the age in a patient over the age of 50, regardless of mechanism of action, should be considered a fragility fracture unless otherwise known, because it may not be the mechanism of action. Even though they had a traumatic fracture, they could still have compromised bone quality because of other medical conditions and medications and lifestyle things, and so they deserve that bone health workup. So keeping that in mind, that would be the stepwise process. Again, there's certain things that you probably want to have in place as you begin to implement your FLS, looking at the number of referrals made compared to the number of eligible patients, appointment no-show rates, treatment compliance, rates of secondary fractures. I'm going to be honest with you folks, this is the stuff that we need that needs to come out in research. We've done a lot of research with FLS programs. We know that those programs have been successful in closing the treatment gap. This is the data that we need to prove that we are making a difference. And so secondary fracture reduction and those kind of things, and all of these patients' treatment compliance, all of those things are so important to know that we're still making a difference, and we can reduce the risk of fractures and also help reduce and prevent the people developing osteoporosis as they age. Again, I have algorithms in place for you here if you're interested in looking at those algorithms. The pledge of our FLS model here at Wake, and this is what I would say to any person who wants to market your program, whether you're marketing as a primary care provider, another specialist, what you don't want to do is alienate anyone else in your organization, thinking that you're trying to steal or poach patients, or you're trying to tread upon their area. You really want to position yourself in a place of showing that you really are about care coordination. So what we say here at Wake is this. We know the patient's going to come to us after fracture. We know they're going to see us in orthopedics. What we're going to do is we're going to care coordinate with you as their providers. And our pledge to you for our FLS service is to provide osteoporotic care in conjunction with the care that you provide to your patient. So we're just basically working with you, whether you've been treating the patient and they failed therapy, or whether they've had this fracture and still been on treatment. Our pledge is to coordinate with you in that. And that actually brings a lot of strong teamwork to the table. It actually rallies in a lot of the other specialists that may have alienated themselves from this. And it really helps to bring that care coordination model to a full circle and puts that patient in the middle, improving their outcomes. So keeping in mind that this is adaptable to any healthcare system, we know it improves patient outcomes, it decreases complications and readmissions related to secondary fractures, and then of course, it's adaptable with any type of healthcare structure, and this is the beauty of it. Academic health systems, integrated delivery systems, independent practice organizations, accountable care organizations, large orthopedic specialty groups, and patient-centered medical homes. So lots of opportunities there. We know about the reimbursement pathway. There's a lot of changes going on there. I tell you, it's so funny, folks, that every time we look at something related to quality-based reimbursement and we get a slide, the slide needs to be updated. So there's so many things that change over time, but this is where we are now with the knowledge of what we have. Keeping that in mind, this is a value-based model of care and improves patient outcomes through care coordination. So having said all that, what I'd like to do now as part of the platform of Project ECHO, and the goal of this with the National Osteoporosis Foundation and the National Bone Health Alliance, is to empower every provider, regardless of specialty, with the knowledge that they need to embrace not just primary prevention of osteoporosis in patients, but true secondary fracture prevention, and identifying those patients that have had those fragility fractures and saying, you know what, either your treatment wasn't working, your bone density may have changed, we need to take a closer look at this chronic disease that's affected your quality of life. So the platform of this program is to actually open up where we can have some case presentations, and I'm sure a lot of you I see on the program have actually been part of a Project ECHO before. But if you're just one of those people that likes to creep around on the program and not get involved, I'm just going to encourage you that when I see you, I want you to know I'll probably be emailing you to do a case presentation or maybe do a didactic, because we have so much to learn from each other, and there's so much valuable information, and I learn something new every day. So I want to open up the platform to do a couple of case presentations, and I'm going to release that back. I'll stop sharing my screen now and release it back to Andrea and let her take it over. Thank you all so much.
Okay, give me 1 second. Okay. So I will be sending around an email with the LMS link so you can do the learning management system in order to get CE credit, which will look like this afterwards. So we'll go with the first case study. Amanda Brown, are you ready? I can scroll down when you need to.
Yes, I am ready. I'm Amanda Brown, and I've had an FLS program in Fargo, North Dakota for about 3 years. My patient that I'm going to be presenting to you guys is a 58-year-old postmenopausal woman who went through menopause in her early 40s. She drinks 2 to 3 glasses of milk daily and also has cheese. You can see her fracture history here. She had one prior to, quote unquote, older than 49 as a wrist fracture. And then the most significant is within the last 1 to 2 years. She fell from a standing height, had a midshaft tibia fracture as well as a fibula fracture. And then shortly thereafter, her birthday, she fell again and had a left tibia fracture. And about 2 months later, after that left tibia fracture, she again had a standing height fall and broke through the hardware. The hardware actually came through her bones. Past medical history-wise, she's got GERD, rheumatoid arthritis. She's been on prednisone since 2002. She does take Neurontin for fibromyalgia. She doesn't have real significant surgical history. I'm not able to scroll down anymore, but if you have the papers in front of you, there we go, thank you. You can see her height and her weight. I did a DEXA scan in February. Obviously the T-scores are a -2.2. Lab-wise, the biggest thing, her vitamin D is 40. She never did get the SPEP done. I'm still waiting for that. But generally speaking, for the most part, everything came back generally good. I don't do bone turnover markers. As far as the medications that are important, she takes Protonix, prednisone, and Neurontin are going to be the biggest ones that we get concerned about. And then as far as her problem list, the biggest things, fibromyalgia, depression, tobacco dependence, migraines, RA, cerebral vascular disease. So I guess the biggest thing is, what would you guys do with this patient? I've started the process, but you know, just some thoughts on naive to therapy, never been on any osteoporotic medicine before, which makes life a little bit harder sometimes.
Okay, so I guess my first question is, does this lady have osteoporosis based on her bone density or her fractures?
My opinion, her fractures.
Okay, so we've established that. So we've established that she needs treatment, yes? Yes. Okay, so does anyone, Dr. Olenjinsky, does anyone want to speak up and maybe give us your treatment opinion if this patient was present in front of you today? Don't forget to unmute.
Okay, well, Ann, it's Elliot. I'll respond. So,
okay.
Yeah, there's a couple of things. First of all, I just go back to the tibia fractures. Now, whether tibia fractures are osteoporotic fractures or not, I think can be called into question. But, you know, certainly the wrist fracture, most people would agree, is a thing. So first thing, though, I would say is, why is this lady falling so much? So I think she needs a falls evaluation, you know, physical therapy, and maybe a neurologic exam. She's taking Neurontin for her fibromyalgia, but you know, in my exam, I would be looking at her vibratory sense, her reflexes, her ability to stand from a seated position, etc. All of those evaluations, even though she's not that old, all of those evaluations of frailty, let's say. Okay, then I didn't hear if a celiac panel was done, but I think it's always a good idea in these patients. You know, and I agree with getting the serum protein electrophoresis done. And of course, we do use bone turnover markers, which may be a topic for another discussion. But with her history of glucocorticoids, I'm not sure if it's current or previous or whatever. You know, this is a patient that I would certainly think about for an anabolic drug to start.
Okay, so excellent. So there's a couple of things. Dr. Olenjitsky, he's having some microphone issues, so I'll speak for him. That he's asking about the dose of prednisone, and is she on any other RA meds like DMARDs?
She is not on any DMARDs, and dose of prednisone, hang on one second. She's currently on 5 milligrams, but I know it was higher at one point in time.
Okay, all right, and then he also said that if she's on a PPI currently, then she really should be on calcium citrate. And I think you and I had kind of discussed this case before, and I think you had mentioned, you know, getting her on that. So that's a great point. Just keep in mind that if a patient's on a PPI, that calcium citrate is the calcium that you want the patient on, because it's going to be able to be absorbed. It does not require acid to be absorbed. So if a patient is on a PPI, it's suppressing their acid. If they're taking Tums or a chewable calcium carbonate and they're on a PPI, they will not be absorbing that calcium. So they really should be switched to the calcium citrate. So that's a great point. And Dr. Schwartz, I absolutely appreciate the fact that you did not go directly to you know, pharma treatment, but you really looked at the whole picture in your presentation of the patient. You first of all said, well, wait a minute, she's fracturing because she's having these falls, so why is she falling? And then you actually looked at her whole medical history and asked some very, you know, significant questions there while you were actually thinking about treatment for reduction of fracture. So I think, I mean, really great points on this fact. So Amanda, has she been sent to physical therapy for core strengthening and balance or Tai Chi or anything like that? Has she done that yet?
Yes, I did send her that, and she is on calcium citrate. I didn't update that, but yes, she has done the physical therapy. I did put a referral into our falls clinic that we have here, where they look at the medications, the gait. It's like a thorough look at the patient if we do have recurrent falls, but that hasn't taken place yet.
Okay.
Yes, this is Avery Jackson.
Yes. Hey, Dr. Jackson.
Hey, Dr. Ann. It's Avery Jackson, a neurosurgeon here in Michigan. You know, and she's obviously pretty young. She's on the Neurontin, and so thoughts about, as you alluded to earlier, other causes of falling. You know, looking at her neuroaxis. So I think a thorough neurologic exam and maybe even a referral might be helpful too. We might find some, you know, that she has an upper motor neuron lesion somewhere that could be a cause. So I wouldn't rule that out. The other piece is I noticed that her height was normal. If it wasn't, given the steroid usage, I'd be thinking about some x-rays of the spine. You know, maybe there could be a partial compression fracture with a burst component causing some central canal stenosis, given your upper motor neuron lesion and affecting her gait or her stability as well. I don't know if she has any pain complaints in her thoracic or lumbar spine.
Not that I'm aware of. I guess I don't recall her complaining of that, or when I asked about back pain, she never said anything regarding that.
Okay.
So one of the things that I would also say is, you know, she has this family history, and so I wonder about her own children and also maybe addressing the familial issue with osteoporosis and good bone health. And this is a good time to also incorporate with her talking about, you know, if she has children, to, you know, make sure that if they are, you know, as they're aging and getting older, make sure they're aware of what she's dealing with, especially with needing treatment and her fractures and those kind of things from a prevention standpoint. So then you're not only doing the secondary fracture prevention, but also the primary prevention as well for the family. So really excellent presentation. Does anybody else have anything to add before we move to the next case presentation?
Yes, I have a couple more things to add.
Okay, great.
So I notice in the lab workup it says phosphorus not applicable. I would disagree with that. I think the patient should have a phosphorus. All bone patients should have a phosphorus or phosphate level drawn, because if it's low, that can lead to muscle weakness. And with the PPI treatment, she should probably have a magnesium done, because there's magnesium depletion with the PPIs, and that could also lead to muscle weakness. And then it also says 24-hour urinary calcium not applicable. And I would disagree with that, because a patient this complicated with multiple fractures, okay, would have a 24-hour urinary calcium, even if she's on calcium citrate, to see what's going on with her absorption, or whether she might in fact even have hypercalciuria. So, all of those things to work up. Then as far as peripheral neuropathy possibly, or whatever, vitamin B12, which we all know can affect neuropathy and pernicious anemia, etc. It's not usually known that vitamin B12 has some significant effects on bone metabolism. So I usually get a vitamin B12 level in these patients also. And I think about 2014, there was a little article in the New England Journal of Medicine on vitamin B12 and bone, which I would suggest everybody could review.
Okay. Excellent comments. Anyone else? All right, thank you so much for your case presentation. That was really exceptional. You've done good work, and if you want to do a follow-up on this lady, we're happy to hear that case again and let us know how she's doing. So I think our next case presentation, Andrea, is Miss Wright on, or I was going to let her do hers. Is she on?
Lisa,
Hello,
are you
here.
on?
I'm here.
Okay,
Can you hear me?
Oh, great. Okay, let's go to hers. Mine was just sort of let's go to hers and spend the rest of the time on hers. How about that?
Okay.
Sounds good.
Go ahead.
Go ahead, Dr. Wright.
Hi, everyone. I'm Dr. Lisa Wright from Crane Clinic in Roanoke, Virginia. I am sharing this case with you on behalf of Dr. Thomas Schuller, who is an orthopedic surgeon, trauma surgeon here at Carilion. This is a very unusual case, and I will say our FLS program is not even started yet, but just my shadowing, I had the opportunity to go in with him on this follow-up appointment. So we have a 72-year-old female Caucasian who was traveling on her way from South Carolina back to her home in Fort Wayne, Indiana. She stopped at a rest area. She got out of the car. She took her first step. She had a simultaneous bilateral subtrochanterial. Yeah, here we go.
Yes.
There we go. Yes, I can't say it today. Femur fractures on 9-3. The interesting piece about her is we really don't know a lot about her. So as you'll see in the note, there's not a lot that is that I can really share about her past history, nor was I able really to go through this with her on the appointment time. She does have a history of diabetes. The medications that she is taking of particular note is Fosamax, which she has been taking for the past 5 years. I was expecting for her to say a lot longer than a 5-year period. I would say that the one complaint that she stated is that she's had tremendous thigh pain for the past 12 months. She just said that she thought it was related to her back, and she didn't make any calls or follow up on this. So for us, our big question is, so we now have a window of time between now and Sunday when she will be en route back to Fort Wayne, Indiana, where she says she will follow up with a physician to manage her care. But we want to, during this very narrow window, make sure that we're crossing every option possible for her, doing any labs that might be warranted as we try to effectively transition her care over to another physician that will take over. I did pull an article from the BMC titled Management of Atypical Femur Fractures and looked at an algorithm which recommended a bone biomarker of the parathyroid hormone, vitamin D, calcium, and then the bone turnover markers of the CTX and the P1 and P. So I am all ears to hear what you guys think we might be able to do in this very short window of time. And then secondarily, is there a person that you might know in Fort Wayne, Indiana that could follow up with her, because we think she really needs some help. So that is the case. And I would say we are assuming that this is bisphosphonate related, so she was told to immediately stop the Fosamax during this time.
Okay, excellent presentation. Let me open the floor up to see who wants to get started on this wonderful case.
This is Angela Chung. How are you doing?
Dr. Chung, hey!
So I'm in Canada. We have a Ontario AFF cohort where we have more than 300 patients, similar to this case. The variation in terms of the duration is very wide. Some patients have only seen it for a short time, as in like months, and some patients have had it for a very long time. And so when we hear about the average duration, you have to keep that in mind. So I'm not surprised that, this lady sounds like has an atypical, bilateral atypical femur fracture, and the presentation is actually very typical of the atypical femur fractures, that they are stress fractures. They present with chronic pain, and if you x-ray them prior to them having the fracture, you will find focal cortical thickening, and sometimes with lucent lines as well. And that can sort of carry on for many years. In terms of management, we actually, in Canada, we have had a sort of group to discuss guidelines for management. And so on the surgical side, the recommendation is to put in IMR or intramedullary rods rather than plates and screws and other things, because there's a very high rate of failure in terms of hardware failure for all the other modalities. And in terms of healing of these fractures, other than being sort of need to be in line with sort of, in terms of the fracture line, the two pieces of needs to be touching. If they're not, if the gap is wide, then it's a problem. And because they're stress fractures, sometimes by pushing them like what we do with our hip fractures, if they have pain, give them a painkiller and get them up and get them walking, sometimes that can be a problem. And so what we try to do is actually to get them to increase their muscle strength without a lot of weight bearing type of exercises, because we try to get them not weight bear as much as by strengthening their muscles per se. And definitely stop all potent anti-resorptive therapies. So need to stop not just the Fosamax, but we are very hesitant with other potent anti-resorptive therapies like denosumab. And for some of these patients, there's some case reports. We are conducting a randomized controlled trial looking at teriparatide, but we don't have results. And so there have been case reports showing healing, maybe faster healing with a bone formation agent. But would be very hesitant to do sort of potent anti-resorptive therapies.
And you just gave this, I believe you just gave this presentation in ASBMR, is that right?
I gave the screening one.
Okay.
I didn't talk about management.
Well, the reason I was asking is if there was a way to get some of that information to Dr. Wright so that she would have that to actually sort of debrief her surgeon on, just to let her know.
Oh, for sure. Yes. So I'm happy to send
Yeah, that would be
the presentation on that. I think the one thing that's important is there can be hypophosphatasia, so a low ALP level, hiding sort of in the patient. So in addition to sort of what you said about sort of doing PTH and vitamin D and all the other things, I think it's important to do ALP. And obviously initially may be high because of the fractures as well, so you may want to repeat it in 6 months' time. And the other important test would be really to, it's to echo Dr. Schwartz sort of saying that need to look at phosphate and magnesium as well, because hypophosphatemia and there are other sorts of osteomalacia as well. So yeah, need to look at those two as well.
Okay. So I guess my question was, do you wait on, do you do all, obviously, do you do all this workup before you actually say, you know, this is related to probably long-term bisphosphonate therapy? Do you, you know, because the patient's obviously been on treatment for osteoporosis in the past, so hopefully they've had a workup before. So do you wait and get all this workup, or would you say, you know, yes, do the workup, but absolutely go ahead and consider initiation of anabolic treatment immediately to stimulate some bone formation and, you know, help that patient within that, you know, window of time? So any thoughts out there?
I'm going to let other people speak.
All right.
Well, Anne, I would say that we would like to at least have some of the workup done. I'd like to know her 25D is normal. I mean, I don't need to wait for a lot of things to come back, because I think there's a place for anabolic therapy, but you know, in the warnings, you want to not have an unexplained elevation of alkaline phosphatase. You want to not have hypercalcemia, but with a minimal workup. Like if I was doing a serum protein electrophoresis, I wouldn't necessarily wait for that to come back. You know, if I had the 25D, the PTH, and the calcium level, I'd go ahead and treat the patient with an anabolic drug. Now, one of the things is that in the Journal of Bone and Mineral Research, Watts and Miller in May of 2017 reviewed a series of patients that had atypical femoral fracture. And while, you know, a 2-year course of teriparatide is expected to help, it apparently does not help healing the atypical femoral fractures. So I agree with Dr. Chung's statement that, of course, there's going to have to be orthopedic approach to both hip fractures.
So we you know, we wouldn't use it for quote unquote fracture healing anyway. It would really be for the underlying issue related to the osteoporotic bone or the poor bone quality. But yeah, to your point, I think if we look at off-label treatment related to fracture healing with any of the anabolics, we need to know, you know, that data behind it. I do have a question though, and I don't know if anybody, you know, has this question as well, but when you're looking at the bone markers, one of the things that I'm curious about, because there's not a lot of standardization behind those bone markers at this point. I know the NBHA and NOF had a working group working on that in the past, but because there's not a lot of standardization, it's really kind of hard to know, well, what does this really mean? They need to be checked in the morning time. What are the standards related to checking bone markers, which I think Ms. Brown had mentioned, you know, she doesn't check them, and a lot of it is because we don't have a lot of good protocols. So I would like to know, are there any really good protocols, and what would we be looking at to see that a patient is responding to treatment? Is it just a 10-point increase in the P1NP? I mean, what are we looking at? I mean, can you give me, anybody got any ideas on that?
Yeah. So we always get the bone turnover markers fasting in the morning between 7 and 10 a.m. So that's after overnight fast. It doesn't have to be a 12 to 14 hour fast like lipid panel, but I usually tell them when they stop eating the night before not to eat anything until the lab is gone, but they can have water because you don't want them going to the lab dehydrated and the lab can't draw them. So they can take water only, no coffee, tea, milk, etc.
Okay.
And then we would look at it. So the issue here would be we would expect that the bone turnover markers would be low or low normal due to the years of alendronate therapy. And then we could follow the P1NP and the serum CTX over time to see that there was an anabolic or bone remodeling response. Now, one of the things that has been pointed out years ago by Ettinger in an article where they looked at raloxifene and alendronate treatment of patients starting an anabolic is that when you're taking alendronate, it's going to take about 6 months probably to get the anabolic response going because the bone turnover is, quote, slowed down or whatever.
Okay.
So,
Yeah.
so you have to realize that. So I probably wouldn't get repeat bone turnover markers for 6 months.
Okay, all right. So are there any, can you direct us to like any references that give us those protocols, or are those just kind of things that have been put together and that's kind of what you're using in clinical practice? Because as an advanced practice provider, we need to have some protocols that we can actually rely on. And so if there's something that you can direct us to, maybe an article or something, that would be great. There is one question that came up, and maybe you can address that as well, but or someone can. I believe Dr. Recker's asking, he said he wanted to get clarification. Was he hearing that an elevated alk-phos could possibly be an early sign of an impending atypical femur fracture with someone on an oral bisphosphonate?
And this is Debbie Uzaldo with NBHA. I just wanted to mention that there was a recent paper published in OI that Elizabeth Leary did on bone turnover standardization, and we're happy to send that out to the group as a link after the echo.
And Debbie, this is Elliot. There was an article in 2011 OI also that was like a European working group that looked at all the bone turnover markers, and that's where they came out that the best ones were P1NP and serum CTX, which most of the studies just do those now. They don't do osteocalcin or bone-specific alkaline phosphatase. But I'd not heard that about the alkaline phosphatase rising. But I would point out, as Angela well knows, and that the year of intense thigh pain that this lady had is well described as part of the prodromal syndrome of atypical femoral fractures. And if he had closer attention, maybe that would have been a time to investigate her, and maybe this episode of bilateral fractures could have been prevented.
Okay, all right. So I have to say we got about 3 minutes left, and again, I'm so happy that everybody's been on board. I want to make sure that you guys remember to get your CEU. There were a couple of things that came up. Dr. Wright, there is Kara Brock is on. She's with the Great Lakes. I can't remember exactly the name of it, but Great Lakes, Michigan Bone Health Project Echo up there with Dr. Jackson's group, and they know somebody in the Indiana area that she could help refer that patient to, so we can get you guys connected. And again, I just want to say thank you to everyone. And if Lisa, Dr. Wright, if you need follow-up and you want to speak with someone else, you can contact me, and we'll be happy to get you connected with another expert in the field as well. Andrea, thank you so much for the case presentation. And Dr. Wright, did you get at least in part what you were looking for today?
I did, yes.
Okay.
Thank you very much. And more or less, opening this, just seeing this is something that I wouldn't think I would ever see. But now I'm very cautious now with any treatment. So yes, yes, thank you. It's very enlightening. Thanks, everybody.
Yeah, well, one of the things they're doing here at Wake is if they have it on one side, they're automatically doing the contralateral view on the other side, and they're actually doing prophylaxis as well. So that is part of our protocol. So again, thank you all so much. I want you to get your CEU, and we want to hear some feedback, what you might like to hear. I'm actually in the process of putting together a calendar flow. Our next presentation, I believe, is scheduled for October 12th, and I've asked Dr. Olenjinsky to be prepared to talk about rheumatoid arthritis medications and how they affect the bone. But if there's other topics, we'd love to hear from you because we want to meet your needs and be connected with you. Thank you all so much. What a strong group. You all look great. Woo! All right, Andrea?
Okay, yeah, so we're all good. I sent the link through the chat right now, but if you can't access the link, it's fine. I'll be sending out an email as well to everyone. And yeah, I've recorded it. Hopefully the session looks good and everything, but yeah, we're all set up. October 12th, the next session.
All right. Thank you all so much. We'll be hearing from you.